Chapter 1, U.S. Medical Care, a System at the Crossroads. Welcome to Mastering MHA MBA. I'm here to teach you healthcare economics, policy, and strategy at the level used in MHA and MBA programs. This lesson comes from Chapter 1 of Health Economics and Policy, 8th edition, written by James W. Henderson and published by Cengage Learning. If you're studying for your MHA or MBA, I highly recommend picking up a copy. Let's get into it. We're starting with the big picture, the contradiction of a system that has unmatched technology but rising costs and uneven access. In this video, we will break down the impact of the Affordable Care Act and explore the iron triangle of healthcare, the constant tug of war between quality, access, and affordability. The big picture. The United States spends more on healthcare than any other country on the planet, and it's not even close. We have some of the best hospitals in the world. Our medical technology is unmatched. Our physicians train for years longer than most other countries require. And yet, Americans remain frustrated with their healthcare system. Costs keep climbing, access is uneven. Quality varies depending on where you live and what insurance you carry. This contradiction sits at the heart of U.S. healthcare. Henderson calls it a system at the crossroads because it's being pulled in three different directions at once: quality, access, affordability. You can push hard on one or two of these, but pushing on all three at the same time, that's where things get complicated. This chapter explains how we got here and why fixing it is so difficult. Section 1, the Affordable Care Act. On March 23, 2010, President Barack Obama signed the Patient Protection and Affordable Care Act into law. You probably know it as the ACA or Obamacare. From day one, this law divided the country. It passed without a single Republican vote in Congress. Supporters predicted that once Americans understood the details, support would grow. That didn't happen. By the November 2010 midterm elections, nearly 60% of voters said they wanted the law repealed. A decade later, opinions hadn't shifted much. Polls in 2020 showed the country still split almost down the middle, what the ACA tried to fix. So what was the ACA actually trying to do? Three main things. First, cover the uninsured. Millions of Americans had no health insurance at all. Second, make insurance more affordable by providing subsidies to help people pay their premiums. Third, protect people with pre-existing conditions. Before the ACA, insurers could deny coverage or charge higher rates if you had a health condition. The law also included guaranteed issue, which means insurers had to accept all applicants. Guaranteed renewability, so they couldn't drop you when you got sick. And it allowed young adults to stay on their parents' insurance until age 26. How the ACA worked. The ACA expanded Medicaid to cover more low-income Americans. It created state-based insurance exchanges where people could shop for coverage. It required individuals to buy insurance or pay a penalty. That was the individual mandate. Large employers had to offer coverage to their workers or face fines. To pay for all this, the law reduced Medicare spending and added new taxes on health plans, medical devices, and pharmaceutical companies. Unintended consequences. Here's where things got messy. The new insurance pooling rules meant everyone went into the same risk pool. Sick people and healthy people, old and young, that's fair in one sense. But it also meant premiums went up for younger, healthier people. They were now subsidizing older enrollees and those with chronic conditions. About 20 million Americans gained coverage under the ACA. That's a real accomplishment. But over 30 million remained uninsured even after the law took full effect. The ACA didn't eliminate the fundamental trade-off in healthcare. It just shifted who pays and how much. The political divide continues. By 2020, Americans were still arguing about what to do next. Some wanted to repeal the ACA entirely. Others wanted to expand it by adding a public option, which is a government-run insurance plan that would compete with private insurers. Some progressives pushed for single payer, where the government would cover everyone. Henderson argues that this political instability reflects deeper economic contradictions in the system. The trade-offs never went away. We just keep arguing about who should bear the costs. Section 2, the three core problems. What Americans worry about. When you ask Americans what worries them about healthcare, you hear the same three things over and over. Quality. Will I get effective, safe, timely care? Access. Can I see a doctor when I need one? Will my insurance cover the treatment I need? Affordability. Can I pay for care without going bankrupt? These three concerns drive every healthcare debate in this country. The Iron Triangle. Here's the problem. These three goals are connected and they pull against each other. If you expand access, costs go up. If you improve quality, that requires investment, which also raises costs. If you try to control spending, you end up limiting access or quality. This is called the iron triangle of healthcare. You can optimize one or two corners, but pushing hard on all three at once is almost impossible. Every policy choice involves a trade-off. The triple aim. In 2008, researchers at the Institute for Healthcare Improvement proposed a framework called the triple aim. The idea was to pursue three goals simultaneously: improve the health of populations, improve the patient experience of care, and reduce the per capita cost of healthcare. This sounds a lot like the Iron Triangle, but the triple aim adds something important. It focuses on population health, not just individual treatment. And it suggests that with the right delivery system design, you might be able to make progress on all three fronts at once. Accountable care organizations. Accountable care organizations, or ACOs, were designed to make the triple aim work in practice. An ACO brings together hospitals, physicians, and other providers into a coordinated network. They share responsibility for the cost and quality of care for a defined patient population. If they keep patients healthy and spending low, they share in the savings. If costs run high, they share in the losses. The idea is that integration and accountability can break through the iron triangle. Whether it works in practice is still being debated. So, we've seen how the Affordable Care Act attempted to address our system's biggest flaws and why the iron triangle makes it so difficult to achieve quality, access, and affordability all at once. But the US healthcare system didn't just appear out of nowhere. It is a product of over 150 years of scientific and social shifts. In the next video, we're going to look back at the history, from the discovery of germs to the birth of the blues, to see how we accidentally built the system we have today. I'll see you in part 2.